Conversations, a clinical podcast presented by Creative Educational Concepts designed to improve clinician performance and optimize patient outcomes. This session, titled Clinical Advances in Ovarian Cancer, exploring the expanding role of PARP inhibitors in the treatment paradigm, is accredited for 1 hour of ACCME, ANCC, and ACPE credit, and is supported by an independent educational grant from GlaxoSmithKline. To earn CE credit for this activity, please visit the link in our show notes to complete the post-test and activity evaluation at the conclusion of the podcast. And with that, we will turn it over to our expert faculty.
Hi, I am Flora Backus. I'm a professor in the Division of Gynecologic Oncology at The Ohio State University James Cancer Hospital in Columbus, Ohio. And I am very honored to work with Creative Educational Concepts to present this presentation that is supported through an independent educational grant from GlaxoSmithKline. Here are the disclaimers. And here are disclosures. And for this, you will receive accreditation up to 1 hour, and more information can be found on the website. Let's go over the learning objectives. So what we want to do today is review the recent updates to national guidelines recommendation in ovarian cancer treatment and testing, and to discuss health equity issues that may hinder ovarian cancer patients from receiving the current standard of care. We will also appraise landmark and emerging safety and efficacy data with PARP inhibitors in the treatment of ovarian cancer, with a focus on the most recent recommendations and rationale for the use of PARP inhibitors in a first-line maintenance setting. We'll analyze unique toxicity profiles among PARP inhibitor therapies and important considerations for both monitoring and managing the adverse events. With that, let's go ahead and get started. So let's start with the management of ovarian cancer and exploring new standards of care. So just a brief background, the incidence of ovarian cancer is estimated to be almost 2,000 new cases and over 12,000 deaths in 2022. The median age of diagnosis is 63, with a median age of death at age 70. Approximately 1.1% of women will be diagnosed with ovarian cancer at some point during their lifetime. And you can see in the graph that the rates of new cases as well as the rates of deaths are slowly improving. The relative 5-year survival currently is approximately 50%. So what do we have in terms of biomarker testing for ovarian cancer? So it's really important that all patients with ovarian, fallopian tube, or primary peritoneal cancer should have a genetic risk evaluation, and they should have at least germline testing, and preferably both germline and somatic testing. Because for one, this also can prevent or inform risk-reducing strategies for the patient and her family, but also informs maintenance therapy and other future therapy options. In the absence of a BRCA1 or 2 pathogenic variant, you can also test for homologous recombination status, and this may provide also information on the magnitude of the benefit of PARP inhibitor therapy. So let's look at how often this actually occurs. So if you have a BRCA1 pathogenic variant, the lifetime risk of ovarian cancer is around 40%, as high as 58%. With the BRCA2 pathogenic variants, this lifetime risk is between 13 and 29%. And approximately 15 to 20% of ovarian cancer patients have a BRCA mutation, a germline mutation. But even higher percent of patients, almost half of the patients, exhibit some form of homologous recombination deficiency, or HRD. Again, the cumulative lifetime risk for other diseases, 72% risk, about 70% for breast cancer, 50% for ovarian cancer, as we mentioned below, but depending on the BRCA 1 versus 2 status. There's also some other cancers that should be considered in males with BRCA1, prostate cancer, for example, with BRCA2, pancreatic, prostate, male breast cancer, very pathognomonic for BRCA2 mutation, and melanoma. So when we talk about ovarian cancer, most of these patients have a high-grade serous ovarian cancer, approximately 50 to 60% of all ovarian cancers. And those are the ones that mostly resemble the fallopian tube. These are, and we think that most of these tumors actually start in the fallopian tube in the fimbriated ends, then land on the ovary, and then develop ovarian cancer. So it's really a continuous spectrum. These tumors are notable for defects in DNA repair, and like we mentioned before, have a high percentage of BRCA pathogenic variants and homologous recombination deficiency. And when we talk about germline versus somatic, germline is when actually this is in all the parental gametes, and so the entire organism carries the mutation, and also this is something that can be passed on to offspring. Whereas if you have a somatic variant, the parental gametes, most of the cells have normal, but there are mutations only in the affected area or in the tumor itself. So these are acquired somatic mutations that appear over a lifetime and are not hereditable. As far as treatment, we think about it is either the patient starts depending on how extensive their disease is and whether they're a surgical candidate, or a complete surgical debulking can be obtained or achieved. We either start with neoadjuvant platinum-based chemotherapy or start with the surgical staging or surgical debulking surgery. Then there's adjuvant therapy, maintenance therapy, and then hopefully they'll never get to this stage of relapse. But if they do, at that point, you'll initiate recurrence therapy and then can use maintenance therapy for recurrence again. Although the recurrence rates are very high, about 70 to 90% of the women will develop a recurrence for those with stage 3 or 4 disease. We also see very high response rates with chemotherapy, up to 80%, and a good, very good chance that we can get these patients into remission, and hopefully a very durable remission. And so what are the recommendations currently for first-line treatments? Like we mentioned, we get disease stage assigned by their surgical staging or clinical staging. Then start with chemotherapy, and then after the patients complete chemotherapy, we have to start making some decisions. If you did not use bevacizumab during the primary treatment, you probably wouldn't add it at this time. You would look at whether they're BRCA wild type or unknown. If they are have a BRCA mutation, you would continue on as long as they had a CR or a complete or partial response to PARP inhibitor maintenance therapy. If they're BRCA wild type or unknown, you can also still use this because niraparib is indicated for all patients. If we used bevacizumab already as part of the initial treatment, you would go down the same graph, but in addition to the bevacizumab maintenance, you would either add olaparib based on homologous recombination deficiency, right here, or if they have a BRCA mutation, you could use the combination. You could use olaparib by itself or use niraparib. And so what are these PARP inhibitors? They're poly-ADP ribose polymerase inhibitors. They interfere with the DNA repair mechanisms, and BRCA mutated cells are more dependent on this mechanism. It directly inhibits PARP 1, 2, 3 and increases the formation of PARP DNA complexes, and that prevents DNA repair and results in cell death. There are 3 FDA-approved PARP inhibitors for ovarian cancer at the moment: olaparib, niraparib, and rucaparib. So how does this work? So if you have a single-strand break, PARP would be recruited to the sites to repair these single-strand breaks. However, if you use a PARP inhibitor, then these single strand breaks cannot be repaired, and it results in an increasing number of double strand breaks. This is where the normal cell can do its repair via the homologous recombination repair pathway, and the cell survives. However, if you have a BRCA mutation, the cell cannot do this repair. And so then you have to rely on the error-prone other pathways for repair, and that leads to further DNA damage accumulation and then results in cell death. So again, in summary, homologous recombination deficiency and this pathway is the only error-free pathway for repair of double-strand DNA damage. HRD means that the tumor cell's DNA repair machinery is not working. And when the tumor has a homologous recombination deficiency, then DNA damage accumulates. PARP is an enzyme involved in the repair of single-strand DNA damage. These PARP inhibitors block single-strand DNA repair, causing the accumulation of double-strand DNA. And then those with intact homologous recombination pathway can repair the double strands DNA damage that's caused by these PARP inhibitors, but tumor cells that are homologous recombination deficient or HRD cannot, and those cells die. So this appears to be a biomarker that's really important to know because the greatest benefit of PARP inhibitors is in those patients that have HRD. So you can determine this in a couple different ways. It can be a deleterious germline or somatic pathogenic variant of genes that are related to this repair mechanism. Or you can also look at genomic instability that is secondary to HRD. And this HRD score can be calculated based on the loss of heterozygosity, or LOH, telomeric allelic imbalance, and large-scale transitions. A high loss of heterozygosity, or LOH, suggests the presence of HRD. So these are can be measured with different scores, and different companies have these different scoring systems as part of their SAM results. Like we said before, 50% of the high-grade serous ovarian carcinomas are homologous repair deficient. And so they have a defect in one or more of the genes involved in homologous repair. And that includes germline and somatic BRCA pathogenic variants, but also other pathogenic variants of genes such as ATM, CHEK2, RAD51, and the MRE11A genes. So as far as the FDA-approved ovarian cancer indications, olaparib is approved for the first-line maintenance of patients who have a germline or somatic BRCA pathogenic variant and a complete or partial response to platinum-based therapy. You can use this either by itself or in combination with bevacizumab for those who are HRD positive based on a companion diagnostic. And it is also indicated for the maintenance treatment of recurrent ovarian cancer after complete or partial response to platinum-based chemotherapy. Niraparib is indicated for first-line maintenance of advanced ovarian cancer if they have a complete or partial response to platinum-based therapy, so independent of BRCA mutation or homologous repair deficiency, homologous recombination deficiency, and also indicated for the maintenance treatment of recurrent ovarian cancer, again, if they have a complete or partial response to platinum-based chemotherapy. Here we also see that this is approved for all comers. Rucaparib is currently only approved for maintenance treatment of recurrent ovarian cancer after complete or partial response to platinum-based chemotherapy. And we'll look at some data in the front line also, and this may change in the near future that rucaparib may also become FDA approved and indicated for frontline therapy, but that is still pending. So what do we have as far as the current data? So the SOLO-1, which was reported in 2021, was a randomized double-blind placebo-controlled phase 3 trial. Primary endpoint was investigator-assessed PFS. The patient population was had to have a known BRCA status, newly diagnosed ovarian high-grade serous or endometrioid ovarian cancer with either a complete or partial clinical response after platinum-based treatment. They were randomized 2-to-1 within 8 weeks following the completion of their last chemotherapy to olaparib 300 milligrams twice daily, or placebo tablets, and this was given for 2 years. So again, all these patients had either a germline or somatic BRCA mutation. So what they then saw was that the median progression-free survival was 56 months in the olaparib group versus almost 14 months in the placebo group. And really the first drop off, you see really steep decline of the curves already in that first year after treatment, where we thought that these BRCA patients always would do great, but we see actually quite a large number of patients already having, half the patients have progressed by that 14-month mark. Whereas we see flattening of the curves and a sustained separation of the curves. And we see that these patients may, even this far out, have not developed a recurrence, and hopefully we'll see that this is cured. So recently also, this was presented for the 7-year overall survival. We see here that with olaparib, the median overall survival has not been reached, whereas with placebo, this was 75 months. So at 7 years, the overall survival was 67% versus 46%, and this is clinically significant. So other than a progression-free survival, we also see that there is an overall survival benefits. If we separate these out further, in a low risk and a high risk group, so those with FIGO stage 3 disease without residual disease after primary debulking surgery, or those with residual disease after primary debulking surgery, or who receive neoadjuvant chemotherapy, we see a sustained benefit in both of these groups in terms of their progression-free survival, with an almost 65% reduction in the risk of recurrence. Let's look at the PRIMA trial. So this was a similar trial, randomized double-blind phase 3 trial. Primary endpoint was, again, PFS. This is for all comers, newly diagnosed stage 3 or 4, high-grade serous or endometrioid cancers, and all patients had HRD testing. They were randomized 2-to-1 to niraparib, 300 milligrams daily. But for those patients who had a weight of less than 77 kilograms or platelets less than 150,000 prior to starting, they were given 200 milligrams daily. This treatment was continued for 3 years, and again, randomized to placebo in the other arm. Similarly here, we see the progression-free survival curves of maintenance niraparib, and this was consistent across all patients, regardless of the presence or absence of HRD. We see a strong separation of the curves here in those patients with homologous recombination deficiency, but also still see a similar separation of the curves here, although a little bit less, with hazard ratios of 0.4 and 0.6 in terms of risk reduction with niraparib. There's been a recent updated long-term progression-free survival now with a median follow-up of 3.5 years. In the overall population, the progression-free survival was almost 14 months versus 8 months. And in the homologous recombination deficient subset, the progression-free survival was 24 versus 11 months. So more than doubling of progression-free survival with longer follow-up. In the PALO-1 trial, this again was a randomized double-blind international phase 3 trial. This is women with HRD positive advanced ovarian cancer, and they were randomized who received platinum-based chemotherapy with bevacizumab, randomized 2-to-1 to the addition of olaparib to the bevacizumab or bevacizumab only. And they were given tablets, 300 milligrams twice daily. So what we see here, again, similar curve. and see that there is separation of these curves. The median PFS in the olaparib with bevacizumab arm was 28 months, and in the bevacizumab with placebo arm was 16 months. Again, similar hazard ratio here also of 0.43. And in the BRCA mutated population, the median progression-free survival with olaparib and bevacizumab was 37 months, compared to 21 for bevacizumab only. So very consistent results across all different agents. Another study of combination PARP inhibitor with endovascular therapy, bevacizumab, was the Ovarian trial. So this was patients with stage 3B or 4 ovarian, fallopian tube, or peritoneal cancer who responded to platinum-based chemotherapy with bevacizumab. And then this was a single arm phase 2 prospective trial. They received either niraparib 200 or 300 milligrams daily, depending on weights and plates, and bevacizumab 15 milligrams per kilogram every 3 weeks. We see here the 18-month and 24-month progression-free survival rates of 62 and 53%, with a median progression-free survival of 19.6 months in this cohort. Again, there's no comparator arm. This is just a single arm trial in the overall population. As far as the HRD population, the 18-month PFS is 76%. And if we look at the curve separated out by HRD status, for those that are have HRD, they have the longest progression-free survival of 28 months. Those that are proficient, a little bit shorter, 14 months, and those that are for who HR status was not known or not done, kind of in between there. Then most recently also, the Athena mono results were reported and published. So this is the women with HRD status, histologically confirmed advanced ovarian cancer with a response to first-line platinum treatment. And so these patients were randomized to rucaparib with placebo, or received placebo and placebo. And this is a 4-arm trial, because they also had 2 arms that contained immunotherapy, and those results will be reported later. So this is just a readout from the mono portion of the trial. What we see here is, again, that rucaparib also in the first-line setting improves the progression-free survival compared to placebo, with a difference of 28 versus 11 months. And in the HRD positive population, in the intent to treat or all comers, 20 versus 9 months. So if we put all these trials together, we see that the median follow-up here is different across all trials, which also results in slightly different progression-free and overall survival rates. But we see here for the SOLO-1, the BRCA mutated population, the HRD population, all broken down, the PRIMA populations, but really across all different subsets of patients, HRD, BRCA mutated, and even the HR proficient patients, significant benefit in, although different, magnitude of benefits in progression-free survival. So in summary, here's your indications. So for first-line maintenance, both olaparib and niraparib are currently approved. Again, this is for BRCA, olaparib is for BRCA mutated patients. And if it's in combination with bevacizumab for HRD positive, niraparib is for all comers. And then for maintenance, don't even have to, I mean, although you should do testing, you don't need the testing information because it's not required to know it's indicated for all patients. So, in summary, women with BRCA-associated ovarian cancer should be offered first-line maintenance therapy with FDA-approved olaparib or niraparib for 2 to 3 years, depending on the trial and the agent that you use. Women with epithelial ovarian cancer may be offered olaparib or niraparib following a complete or partial response to platinum-based chemotherapy. And those who are treated with bevacizumab concurrently with chemotherapy and are HRD positive may have olaparib added as maintenance therapy for up to 2 years following the complete or partial response to treatment. So as we see more and more of these patients treated with PARP inhibitors, how do we manage the adverse effects that are associated with PARP inhibitors? Well, let's look at that in a little bit more detail. So here are the dosing strategies. You see that they're all a little bit differently dosed. Niraparib is the only one who is given once a day. Rucaparib, olaparib are both given twice a day. There are different formulations available. And then the recommendations for monitoring parameters for olaparib and rucaparib, blood counts should be checked at baseline and then monthly thereafter, along with renal function. For niraparib, it's really important because we see a little bit more thrombocytopenia with this and if this happens, usually happens within the first week. So really important to monitor their platelets and the blood count weekly for the first month, then monthly for a year, then every 2 to 3 months. You should also monitor blood pressure and heart rate, as niraparib can also increase both of these. Weekly for 2 months, and then monthly for a year, and then every 2 to 3 months thereafter. They're all metabolized through slightly different enzymes and some of our CYP enzymes, as you can see here. And this is important to know when patients are also on other medications. So there's some drug-drug interactions that we know with olaparib. So drugs that are CYP3A4 inhibitors, such as fluconazole or itraconazole, this can increase olaparib concentration. And for those CYP inducers, it can decrease olaparib exposure. With niraparib, there are not no significant clinical drug studies that have been performed with niraparib, but no known interactions, significant interactions. And then as far as rucaparib, patients on warfarin, midazolam, omeprazole, and digoxin, we see that can be these drugs can increase the serum concentration of rucaparib. So important to realize also. Some of the other transporters that are associated with this also, yes, the metabolizers, but there's also other renal transporters that we have to remember that both the rucaparib and olaparib can increase creatinine levels, not due to renal function, but related to the renal transporter. So we don't have to make adjustments for that if they start bumping their creatinine just slightly. If we look at other adverse events, the most commonly reported grade 3 or 4 here. Fortunately, the grade 3 or 4 side effects are very low. So here's the percentages in the somewhere between 1 and 10% as far as our most of these side effects. If we look at anemia, a little bit of small differences here between PARP inhibitors. Neutropenia, thrombocytopenia is probably the most pronounced one, where niraparib has more thrombocytopenia, although it has gotten a lot better with the uptake of the weights and plates rule. Nausea and fatigue, certainly very common and very similar around with agents. So what should you do? For anemia, a blood transfusion may be given for symptom relief or for hemoglobin levels less than 8. If there's progressive anemia or persistent anemia, you can also consider using growth factors, and certainly holding PARP inhibitors until levels resolve until 9 or so, and then resume at a reduced dose. If thrombocytopenia occurs, then you want to hold if the platelets are less than 100,000 and resume after the platelets are back up to 100,000. While you can resume at the same dose, most of the time you would after holding you would resume at a lower dose for niraparib, so reduced by 1 dose level. And then neutrophil counts less than 1,000. And for neutropenia, grade 4, that is lasting more than 5 to 7 days, or neutropenia with a fever, you want to hold the drug until the neutrophils resolve to over 1,500. And if there's a recovery, of course, if you have an infection, and then resume again at a reduced dose. Growth factor is not indicated on therapy, but you could consider this if needed while the drug is being held. Couple words of caution: myelodysplastic syndrome or acute myeloid leukemia. Overall, there's a low incidence among all agents, less than 1.5%. But all agents also continue to recommend this is in the frontline setting. So all agents recommend CBC monitoring. If your counts do not recover in 4 weeks, then you have to evaluate your patient for MDS or AML. And important to know that we have to counsel our patients about this too, because the majority of the events had a fatal outcome. Remember to do your baseline and monthly labs, and of course, discontinue if MDS or AML is confirmed and refer to hematology in these instances. As far as bone marrow suppression, we talked about this. Interrupt the PARP inhibitor, monitor blood counts weekly until it's recovered to grade 1 or less, and then consider restarting at a lower dose. Even if you see thrombocytopenia that's really profound, like a grade 4 thrombocytopenia, these do quickly resolve and typically resolve, and then restarting them after the platelets have recovered at a lower dose is typically sufficient. You do not need to necessarily switch to different agents or stop permanently. Fatigue, encourage physical activities, but also periods of rest, maintaining good nutrition, sleep health, sleep hygiene. For nausea and vomiting, consider moderate to high emetogenic. The PARP inhibitors are considered moderate to high emetogenic risk by the National Comprehensive Cancer Network. And so you should, if you write for PARP inhibitors, you should also write for an antiemetic that patients can take about 30 minutes before they take their pills. Not everybody needs this, but that should be on hand. Also important to remember that most of these side effects, fatigue, nausea, vomiting, are mostly self-resolving within the first 3 months or so. So the first 3 months, the incidence will go up, but the body will adapt, and really working with your patients to try and keep them going on their PARP inhibitor and providing them with good supportive care. As far as hypertension, this is a side effect that is pretty specific to niraparib. We see about 5 to 9% that is grade 3 or greater. Therefore, there is blood pressure and heart rate monitoring, like we mentioned before, at least weekly for the first 2 months and monthly, and medically managed antihypertensives. You wouldn't necessarily hold your PARP inhibitor for hypertension, but you do need to watch these patients and start them on antihypertension. You certainly can make an adjustment in your niraparib dosing if it's not able to be controlled with antihypertensives. If patients have seizures, headaches, altered mental status, visual disturbances, cortical blindness, with or without hypertension, think about posterior reversible encephalopathy syndrome, or PRES. It is a very rare symptom, but the diagnosis requires confirmation by brain imaging, preferably by MRI, so keep this in mind. Pneumonitis can also occur around 1% or less than 1%. Olaparib has been documented for this. Presents with new or worsening respiratory symptoms such as dyspnea, cough, fever, or radiographic abnormality occurs. In that case, you want to interrupt. and promptly assess the source of the symptoms. And if it is confirmed, then you need to treat the patients appropriately for their pneumonitis and symptoms that may be with steroids. And if it's severe, you may also even need to discontinue your treatment with your PARP inhibitor. As far as cancer care disparities, so health disparities are differences in health that is closely linked with social or economic or environmental disadvantage that's often driven by the social conditions in which the individual lives, learn, work, and play. And this is the definition by the National Cancer Institute. And so some of the etiology of these health disparities are listed here in this graph: racism, discrimination, segregation, structural inequities, and social injustices, then adverse differences in social determinants of health, which can lead to disparities in cancer care continuing, lack of diversity in the workforce, and even result in adverse health outcomes. And so some of these factors also, and because most women present with late-stage disease and standard treatment requires complex and surgical medical management, disparities in ovarian cancer are closely related, closely tied to guidelines adherence in treatment. And so there's other factors associated with non-guideline adherent care, includes Black race, low socioeconomic status, treatment at low volume hospital or with a low volume surgeon, non-white race, Medicaid insurance, lack of insurance, non-English fluency, and all these factors are negatively associated with enrollment to clinical trials as well. So we really have to monitor these, that we make sure that we provide equal and excellent care for all of our patients, independent of any of these factors. And enroll these patients also, all of these patients and all patients, give them access to clinical trials, as this is how we advance the standard of care and how we've made so much progress in ovarian cancer recently, but make sure that all populations are represented so that we can have a true result that is applicable to all subsets of patients. There are, and this is important because there are racial and ethnic differences in the incidence of pathogenic variants in genes, for example. If we look at BRCA1, in ovarian cancer, whites 7.2% versus Hispanics 16.1%. And so things that we can do to address potential healthcare disparities are in terms of communication and cost. We need to make sure that there's good communication between patient and provider, acknowledging patient beliefs and values, decreasing the healthcare provider bias and implicit racial bias, and increased representation of minority providers within the oncology workforce. We have to decrease or we have to improve and decrease the treatment costs with co-pays assistance cards, patient assistance programs, and provide grants to cover transportation costs and independent care so that patients can go to high volume centers and places where there's excellence of care and clinical trials available, and provide help navigating insurance claims and financial assistance programs. And hopefully this can overcome gaps in outcomes research also by increased representation of minority groups in clinical trials. And this would allow us to evaluate genetic and molecular differences in tumor biology based on race and other factors as well. So as far as clinical considerations, a multidisciplinary management between the primary care physician, palliative care team, case manager, navigator, social support, genetic counselor, looking at comorbidities, other medications, help from the oncology clinical pharmacist, patient support, some items that we just discussed, understanding of the disease and the treatments, reviewing all these options, risks and benefits, comorbidities, having access to learning, whether that's handouts or videos, allowing time for questions, reviewing who to call and where to call, and evaluating these barriers to care, whether that's financial, transportation, health literacy, cultural, LGBTQ concerns, language barriers. Any of these we need to evaluate to provide good care and equal care to all of our patients. So in summary, genetic and genomic testing are critical aspects of treatment planning. The PARP inhibitors exploit homologous recombination repair pathways, and depending on the line of therapy, PARP inhibitors can be used regardless of HRD status. And patients with BRCA variants or HRD positive patients derive significantly greater benefit from PARP inhibitors than patients who are HRP proficient. The choice of PARP inhibitor depends on numerous factors, such as line of therapy, the tumor genetics, adverse event profile, disease characteristics, and prompt identification and management of side effects of PARP inhibitors can minimize the impact of patients' experience and adherence to their treatment also. Furthermore, addressing potential healthcare disparities enables patients to receive guideline-recommended, evidence-based healthcare and better results and outcomes in terms of survival.
Thank you for attending this edition of CE Conversations. We hope it has been impactful for your clinical practice and most importantly for the patients you serve. Please proceed to the link in the show notes to complete the post-test and activity evaluation to claim your CE credit.